Good afternoon, everyone. Today, we're going to take an in-depth journey into the complex world of heart health. Our focus will be on four interconnected aspects: cholesterol buildup, arterial calcification, myocardial infarction or heart attack, and the formation of heart scars. We'll explore their mechanisms, how they relate to one another, and the rationale behind the modern treatments we use to manage these conditions. This article provides a comprehensive overview, and my presentation will highlight the key takeaways. To truly grasp heart health, we need to understand that these conditions aren't isolated. They are deeply interconnected, forming a continuum of cardiovascular disease. We'll start by looking at cholesterol buildup, known as atherosclerosis, which is a chronic inflammatory process affecting our artery walls. Then, we'll move on to arterial calcification, where arteries harden due to calcium deposits. These two often set the stage for a myocardial infarction, or heart attack, an acute event where blood flow to the heart muscle is blocked. Finally, we'll discuss heart scars, or myocardial fibrosis, which are the lasting structural changes that occur after a heart injury. Understanding this interplay is crucial for effective prevention and treatment. Let's begin with atherosclerosis, commonly known as cholesterol buildup. It's vital to understand that this isn't just cholesterol passively sticking to your artery walls. It's a dynamic, chronic inflammatory process. It starts with damage to the inner lining of the artery, called the endothelium, often caused by factors like high blood pressure, smoking, or elevated, bad LDL cholesterol. When LDL particles enter the artery wall and become oxidized, it triggers an immune response. Macrophages, a type of white blood cell, engulf these oxidized LDLs, transforming into foam cells, which are the earliest signs of plaque. Over time, smooth muscle cells migrate to the area, depositing more material, and forming a more complex plaque with a fatty core and a protective fibrous cap. Fortunately, we have several powerful tools to combat atherosclerosis. Statins are cornerstone medications. They work by inhibiting an enzyme in the liver crucial for cholesterol synthesis, thus lowering LDL levels. Beyond just lowering lipids, statins also reduce inflammation and stabilize existing plaques, making them less likely to rupture. Ezetimibe works differently, by blocking cholesterol absorption in the intestines. A newer class of drugs, PCSK9 inhibitors, significantly reduce LDL by increasing the number of LDL receptors on liver cells, leading to more efficient removal of LDL from the bloodstream. Excitingly, as of 2025, oral PCSK9 inhibitors are in late-stage development, offering a more convenient alternative to injections. Bile acid sequestrants also help by promoting the liver to use more cholesterol to produce bile acids. And of course, lifestyle modifications, a healthy diet, regular exercise, and quitting smoking, are fundamental, as they directly address the root causes of endothelial dysfunction and lipid accumulation. A key update for 2025 is a shift towards more personalized cholesterol targets, moving away from rigid LDL numbers to a risk-based approach that considers individual factors like inflammation markers and coronary calcium scores. As atherosclerotic plaques mature, they often undergo calcification, a process previously thought to be passive but now understood to be biologically active. Arterial calcification involves the deposition of calcium phosphate crystals within the artery walls, frequently within existing plaques. This isn't just simple mineral buildup, it's an active biological process that remarkably resembles bone formation. Vascular smooth muscle cells can transform into bone-like cells, contributing to mineralization, and inflammation plays a crucial role. Currently, we don't have medications that can directly reverse existing calcification. However, managing the underlying atherosclerosis and inflammation with statins and blood pressure medications can indirectly influence its progression. New research is also exploring agents that specifically target calcification pathways. When calcification becomes severe and obstructs blood flow, procedural interventions are necessary. Rotational atherectomy can physically grind down calcium deposits, while a newer technique, intravascular lithotripsy, uses sonic pressure waves to fracture the calcium, making it easier to perform angioplasty and stenting. The severe or unstable plaques we've discussed, especially those with significant calcification, are prone to rupture, leading to an acute crisis, a myocardial infarction, or heart attack. This occurs when blood flow to a part of the heart muscle is severely reduced or completely blocked, most commonly by a blood clot forming on a ruptured atherosclerotic plaque. The cascade of events is rapid. The plaque ruptures, exposing thrombogenic material, which quickly attracts platelets and forms a blood clot. This blockage starves the downstream heart muscle of oxygen and nutrients, leading to cellular injury and death if blood flow isn't restored quickly. Immediate emergency treatment focuses on rapidly restoring blood flow, either through clot-busting drugs, thrombolytics, or percutaneous coronary intervention, which involves angioplasty and stenting. Long-term, secondary prevention is crucial to prevent future events and manage damage, using medications like beta blockers, ACE inhibitors, statins, and antiplatelet drugs, along with cardiac rehabilitation. As of 2025, post-MI care emphasizes tailoring dual antiplatelet therapy based on individual bleeding and ischemic risk, and SGLT2 inhibitors are gaining ground for their potential to reduce heart failure development even in non-diabetic patients. The damage caused by a myocardial infarction initiates the heart's reparative processes, but this often results in permanent structural changes, specifically heart scars, also known as myocardial fibrosis. This is the pathological accumulation of collagen and other components within the heart muscle, typically as a healing response to injury like a heart attack or inflammation. However, chronic stress can also lead to it. Following injury, inflammatory cells rush to the damaged area. Fibroblasts, specialized cells, are activated and begin to proliferate, depositing collagen to provide structural support. While this is initially beneficial for healing, excessive fibrosis impairs the heart's function because scar tissue lacks the contractile properties of healthy heart muscle cells and can disrupt the heart's electrical signaling. It's important to understand why current medications don't remove established scars. Mature scar tissue is composed primarily of dense, non-living collagen fibers. Our current medications work by influencing ongoing biological processes. They can modulate pathways that contribute to further fibrosis or reduce the workload on the remaining healthy heart tissue, but they don't have the mechanism to break down and replace the already formed, dense collagen matrix of a mature scar with functional muscle cells. Heart scars can unfortunately lead to or worsen heart failure, creating a vicious cycle. They reduce the heart's ability to contract effectively, increase its stiffness, and can cause electrical instability, all of which contribute to heart failure. Conversely, chronic heart failure can also promote further fibrosis through ongoing inflammation and hormonal activation. Given the limitations in removing established scars, current medical treatment focuses on managing their impact and preventing further progression. ARNIs, or angiotensin receptor neprilysin inhibitors, are key as they have antifibrotic and vasodilatory effects. ACE inhibitors and ARBs block the renin-angiotensin system, reducing levels of angiotensin II, a potent stimulator of scar formation. Beta blockers help by reducing the neurohormonal activation that contributes to fibrosis. Mineralocorticoid receptor antagonists block aldosterone, another hormone with profibrotic effects. A major update for 2025 is the strong support for SGLT2 inhibitors, which are now considered a cornerstone in heart failure management, even for patients without diabetes, due to their ability to reduce inflammation, oxidative stress, and fibrosis. Despite the challenges, the quest to directly target and reduce heart scars is an active area of research. we are exploring several promising investigational therapies. Antifibrotic agents, like pirfenidone, which are used in other fibrotic conditions, are being studied for their ability to inhibit collagen synthesis and fibroblast proliferation in the heart. Galectin-3 inhibitors target a molecule involved in inflammation and fibrosis, showing promise in preclinical studies. Stem cell therapy offers the exciting possibility of transplanting stem cells that could differentiate into new heart muscle cells, replacing scar tissue with functional muscle. And finally, gene therapy approaches are being explored to deliver genes that promote new blood vessel formation or inhibit fibrotic pathways. These represent the cutting edge of heart health research. Before we conclude, let's bring everything together by illustrating the interplay of these conditions. What's crucial to grasp is that cholesterol buildup, calcification, infarction, and scarring are not isolated problems. Instead, they form a progressive chain of events that can profoundly impact heart health. It begins with atherosclerosis and calcification, which contribute to the formation of vulnerable plaques in our arteries. Should one of these plaques rupture, it can trigger an acute event, a myocardial infarction, or heart attack. The heart's natural healing process after an infarction often results in scarring, also known as fibrosis. And unfortunately, that scar tissue can significantly impair the heart's function, increasing the risk of, or worsening, heart failure. Understanding this sequential progression is paramount, as it pinpoints the most crucial moments for medical intervention and proactive management to break this chain. To wrap up our comprehensive look at heart health, let's reflect on the key takeaways. The complexity of cardiovascular disease demands a holistic strategy, one that seamlessly integrates preventative measures with timely, advanced medical treatments. We're fortunate to live in an era of empowering advances, with modern medicine continuously evolving. From personalized cholesterol targets to the expanded use of SGLT2 inhibitors and cutting-edge procedural techniques like intravascular lithotripsy, the 2025 updates highlight our growing ability to manage and mitigate risk. However, amidst these innovations, the enduring power of lifestyle cannot be overstated. Your daily choices regarding diet, exercise, and avoiding smoking remain absolutely fundamental in preventing disease progression and supporting long-term cardiac well-being. Looking to the future horizons, exciting research is underway, exploring targeted therapies that aim to directly address and even reverse existing heart damage, offering new hope. Ultimately, being informed about these processes isn't just academic. Active engagement in understanding your heart's health empowers you to make informed decisions and partner effectively with your healthcare providers, charting the best course for a healthier heart.